Welcome back, everyone. We're now diving into the first session of the conference, and I'm very pleased to introduce our first speaker, Shane Solomon. Shane is the chair of IPA's board, the pricing authority, and has over 30 years of international and national healthcare management experience. Shane currently provides health strategy and advisory services and has non-executive director roles. Prior to this role, he was the founding managing director of Telstra Health, a new eHealth business within Telstra. Shane was KPMG's partner in charge of healthcare. In this role, he worked with state and Australian governments, along with private sector health organisations. Shane was the chief executive of the Hong Kong Hospital Authority, managing 51,000 public hospital staff. During his 5-year tenure, he implemented significant funding and service quality reforms, including a casemix pay-for-performance model and the ongoing development of a comprehensive integrated eHealth system. In Victoria, Shane was Under Secretary of Health at the Department of Human Services, as it then was, where he was responsible for managing the funding system, including casemix for Victoria, and performance and governance of Melbourne Metropolitan Health Services. He was responsible for developing the Hospital Admission Risk Program and governance reforms to Victoria's public hospital system. Shane was the first Group Chief Executive Officer, of the Integrated Sisters of Mercy Victorian Hospital and Aged Care Services Group, merging public hospitals, private hospitals, aged care services and palliative care services into a single new organisation and expanding the Sisters of Mercy mission from 5 entities to 12. Thank you, Shane.
Thanks very much, Sarah, and welcome everybody to ABF Conference 2021. Yesterday, IPA had its 95th meeting and is pushing towards a century of meetings. I'm not sure we should be proud of that. It's also nearly the end of my 10-year tour of duty from the start of IPA in 2011. These milestones, I'm sorry, come with the indulgence of a bit of personal reflection. What have we achieved? Where are we now? Where do we want to be in the future? There are the experiences that come to mind for me personally, like before we had our first meeting in 2011, an important person telling me, well, IPA would not last 6 months. Then with the election of a new government in 2013, being told we were to be abolished along with many other statutory bodies. We stayed in limbo for over a year, just keeping on doing our job. And eventually we were pulled off organisational death row. There was the day in the members' room overlooking the magnificent Adelaide cricket ground where 8 ministers and their department heads took it in turns to attack James and I for more than an hour over a decision we had made. If I didn't know it before, I realised that day that making decisions about the allocation of over $20 billion of Commonwealth funds is not for the faint-hearted. And there were the unrelenting board papers, beautifully written by the IPA staff, but always long. We are intercounting at IPA, as you may know, so of course you need to know that we have read around 54,000 pages of board papers over the years at an average of 564 pages per meeting. In the early days, they were routinely over 1,000 pages per meeting. Authority board members joked that when we worked out our pay rate for reading board papers alone, it was much less than a kid at McDonald's would earn. There was the excitement and challenge of the early decisions made in a hurry to get the first NEP determination out in 6 months, but which required the focus, courage, and problem-solving capability of a very talented board. Those hurried decisions have mostly stood the test of time. From the beginning, we set ourselves some cultural norms with 3 main behaviours that still define our MO. Transparency. Everything we did would be open to scrutiny and test, and that scrutiny became our quality control system. Evidence-based decisions. We wanted to be driven by the data and not do deals to satisfy particular interests or political imperatives. Independence. We wanted to keep an open mind and listen to solid argument and perspectives and not be defensive. And in the end, we knew we had to make decisions that would not please everybody, so maintaining independence was fundamental to us. But what matters is what has been achieved for the Australian healthcare system. I'll touch on these achievements first, then look to where we are now, where funding needs to go in the future, in my view. So the past achievements. How many of you have asked or been asked which is the best health funding system in the world? In the past, I used to try and be clever and answer that question. I've come to realise that there is no best health funding system. Each is grounded in the society where they are born and raised. Health funding systems are a tool for achieving greater goals, including economic and social goals, alongside better population health goals. Health funding creates powerful incentives that influence behaviour across a massive system. So it is essential to be clear what incentive a funding system is meant to create and keep coming back to the why of funding systems. The new ABF system was intended to achieve 4 things. Fairness in funding. A hospital, regardless of where it is in Australia, should receive the same Commonwealth funding for the same service. A cataract surgery at the Royal Melbourne should be funded the same as the Royal Adelaide. Difference in price for services between hospitals should only be where there are unavoidable cost variations as defined in our legislation, such as remoteness or Indigenous status. Transparency. The cost of hospitals and how much they are funded by Commonwealth and state territory governments should be out in the open. No funding on the basis of who is the best at lobbying for money. Transparency is coupled with benchmarking, which allows people to compare their performance against others for the same type of service. For the first time, there was a detailed national benchmarking model adjusted for patient complexity. The system was intended to introducing ABF should improve the efficiency driven by the transparency and benchmarking of the new system and funding tied to treating extra patients, not just for existing. The more expensive hospitals or parts of hospitals would be pressured to come back to the norm or benchmark price. The outcome is greater productivity as the available resources are used more efficiently to treat more patients. Fourth, the new system was intended to increase the share of Commonwealth contribution to public hospitals. In exchange for all states and territories introducing an ABF system to fund their public hospitals, the Commonwealth committed to move towards a greater share of the cost of delivering services, particularly growth services, with Commonwealth funding activity growth by 45% of the National Efficient Price, or NEP. These are powerful incentives and they have largely had the intended effect. The annual growth in the casemix adjusted cost per service has slowed considerably to be more like the general inflation rate in the economy. Before the ABF system, cost per NWOW nationally was trending upwards to 7.2%, has since kept around 2%. With cost inflation at a sustainable rate, growth in funding can be directed to delivering more services to patients. Not surprisingly, activity-based funding has incentivised more activity. Of course, COVID-19, as you can see on this graph, has had a dramatic impact of patients treated more recently over the 6 months of last year. While extra activity is not necessarily all good, more of that later, it means a lot to those who are sitting on waiting lists waiting for a hospital service, or who spent excessive times in ED, or to busy hospital staff trying to cope with the increased demand. Another objective, the Commonwealth contribution. It has increased as intended. The Commonwealth proportion of hospital funding has increased from 33.6% in 2012-13 to 43.4% in 19-20. Importantly, the growth in Commonwealth funding has not led to a decrease in state territory funding. For hospitals, it is the combined funding that ultimately matters. And there was always a risk that the increase in Commonwealth funding would be offset by states and territories reducing their funding levels. Since the new funding system went live, the Commonwealth has increased funding to public hospitals by $9.5 billion and the states and territories by $9.7 billion. Effectively, growth funding is back to 50-50. The same as when Medicare started decades ago. So ABF version 1.0 incentives have achieved the desired outcome. Growth in cost per service dampened, patient service activity up more than price inflation. Commonwealth contribution increased, combined funding to public hospitals from the Commonwealth and states territories grown significantly. So where are we now? At the age of 66, the great David Bowie released one of his best songs, a somber reflection called where are we now? And mine is a bit the same. The achievements I've mentioned relied on a few critical success factors. Determination from all parties to make the new system work. There was a sense of excitement and pride in creating a national system, alongside a respect for states' legitimate cost variations. It convinced me that states and territories and the Commonwealth can work together to get the best out of the talent across our federation. It relied on robust debate amongst stakeholders, recognising the need to compromise jurisdictional interests to make the overall system work. From IPA's perspective, it relied on a vigorous self-criticism whereby we were willing to admit when we didn't get things quite right and find ways to rectify these, not sweep things under the carpet. Above all, it required courage to take risks, and things didn't quite go as planned. We could find a way through. So where are we now? My general feeling is that we are in still waters, where there is a general lack of courage and willingness to take risks. On my more somber David Bowie type days, I say to myself that with the environment at the moment, we could never have done what we did then. Let me give you some examples of where we need to refine our courage. We have new and better ways of funding teaching and training, mental health and emergency department services, but introducing them has been like pulling teeth. Sometimes there are solid arguments for improvement, but more often it is just an aversion to risk. Let's not take the chance. Access to IPA's online portal with the complete comparative benchmarking costing data is still kept in the hands of too few people. It should be publicly available so that the benchmarking potential of ABF can be totally realised. To move to the next stage of funding reform, we need to link patient data sets across programs and jurisdictions, which requires routine collection of the individual health identifier, the IHI. Some jurisdictions are quietly getting on with this, and I thank them for that, while others keep coming up with what an ex-boss of mine called reasonable reasons for why they cannot. What about the future? So to find our courage again, it may help to find a new agenda for the future that gets people excited and willing to take risks so we can keep moving forward. What might that look like? The most common direction is that we should not be paying just for activity, but rather for value and outcomes. And I say here, 100%. But then we have to have the debate on what value and outcome actually means. I have my view, but I don't believe there is a consensus in Australia at the moment. We need to move beyond one-liner cliches to deepen our shared understanding of value as defined by consumers and by the clinical evidence. Then we would need to measure it, count it, then frame a funding system around it. The cynical part of me says that such high-level thinking about value and outcomes lets everyone off the hook. Because we can't operationalise it, then we don't do anything. This is where perfect becomes the enemy of the good. IPA's work on pricing hospital-acquired complications and now hospital readmissions illustrates how practical reforms are possible that provide added incentives to improve the quality of care, and so move beyond activity to incentivising value and outcomes. I believe there are further major funding reforms that are realistic within the system of funding that we have, and which we at IPA can advance. Indeed, the recent National Health Reform Agreement Addendum requires it of us. So back to the beginning of this presentation. There is no perfect funding system, just ways of funding that incentivise behaviours that, if designed properly, do we wish to create in the future. While one-off hospital episodes of care will continue to be important, challenges for healthcare have been changing now for some time. You know them all. The growth in the older population with chronic and complex conditions who bounce in and out of hospital and around the system, and new models of care that make greater use of subacute and home-based care, and now exciting proliferation of telehealth. The focus of the new models are on continuity of care at the individual level, not individual episodes of hospital care. IPA will soon release a discussion paper that canvasses two shifts in incentives. First, paying for bundles of care. For example, a bundle could be a hip replacement, combining the acute hospital stay, subacute rehabilitation in a centre or home, and telehealth. How might a bundle work? Well, existing IPA data can identify current normative patterns of use across the country, at least in part. The bundle would be informed by clinical evidence of best practice care pathways. The incentive then is to substitute the type of service that will achieve the best outcome for the patient, which is most likely to be less time in acute hospital and more resources on ambulatory rehabilitation programs. Measuring success would need to look at both total cost and more clinically and patient-focused outcome measures. This model is best suited to services where there is a combination of services needed across settings, but for a fixed period of time, such as the hip replacement. The second major shift is paying for a period of care or a capitation model. This would target those patients who are hospital frequent flyers and whose needs are likely to be ongoing and often complex with multiple conditions and confound. The incentive here is to substitute the most effective service intervention, often designed flexibly for the needs of the individual circumstance. The outcome should be a reduction in the use of acute hospitals along with measures of patients' health outcomes. The most recent go at this has been Victoria's HealthLinks program, and there's much to learn from this effort. Like IPA's other patient classifications, such a model would need a different payment for different types of patients. Let's call it a case mix capitation model. It would also need transparency, both in terms of which patients get what level of funding and in reporting of outcomes. Both models, the bundling and the capitation models, would draw on IPA's existing pricing work to create a bundle or capitated payment. IPA has done some very interesting work on which patients are most likely to be suitable for the three different funding models. One, the continued ABF episodes of care defined by settings, as we have now, service bundles across settings, but which are time limited, and capitated, adjusted for patient complexity, which are not time limited. In summary, IPA's work has found that the existing ABF model is likely to be suitable for 70% of patients and 51% of total funding. Service bundles may be best suited to 19% of patients who currently use 21% of resources. And capitation for the high user patient cohort could be suitable for 11% of patients, but those 11% consume 28% of funding. This work's very preliminary, but does give some dimensioning of the potential of the new incentive models, and they are substantial. The challenge is then to translate this indication, which could be used to determine the prices of the different models. A particular challenge is how to classify and price the capitation group. Using a cart approach, IPA identified a number of primary diagnosis groups with potential for capitation funding. These have 3 to 4 times higher costs than those patients not in this group. So they're clearly differentiated. The highest cost group was chronic kidney disease stage 3 to 5, with over 100,000 individuals and an annual cost per person of $16,620. Analysis of this group showed significant variability in costs. For example, a relatively simple patient in this group, comorbidity of heart disease or non-infective enteritis or colitis, costs an average of $11,862 per annum, while a more complex patient who is under 75 with chronic heart failure and is indigenous has an annual cost of $48,449. There are clear differentiation in patient types that would justify a case mix classification model. The potential for innovative service responses for these groups is large and I think very exciting and would move us away from simply rewarding and incentivizing hospitalization. The critical success factors for such a shift would include clinical engagement to define the bundles of care and to ensure the classification of capitation is clinically met, data through use of the individual health identifier. So bundles are created which do not lead to double payment, such as where payment of the bundle of care is delivered as well as through hospital funding. A fundamental reorientation of what public hospitals are responsible for. They would need a much more active outreach presence beyond the grounds of the hospital. It would need lots of work on funding model design and lots of technical work. And can I say the obvious, it needs courage to take such a step. It also needs us to determine who would be the fund holder, particularly for the capitation model, because it carries greater risk. Personally, I think LHNs are best placed because they have the capacity to absorb the risk and the capability to design and deliver the clinical components. It will need robust evaluation to determine what interventions and substitutions work the best to reduce acute hospital use and improve health outcomes. With courage and willingness to take risks, such a future model is possible and would take Australia into a world-leading position, as we have done before with acute case mix funding. So in closing, I want to say the most important critical success factor for the past, the present and the future is people, of course. So I want to thank the many people in the wider IPA family who are critical to our success: the Clinical Advisory Committee, Jurisdictional Advisory Committee, Technical Advisory Committee, the many people involved in the technical work around our classification systems. They demonstrate how it is possible for jurisdictions to work collaboratively together, for clinicians to provide valuable advice, and for technical experts to improve the sophistication of our work. Finally, I want to take the opportunity to thank the IPA staff under CEO James Downey for the truly exceptional quality and thoroughness of the work they produce for us on the Authority Board. They are a crack team. Finally, I thank the long-suffering Authority Board members who month after down through their board papers, and they do read them and contribute so much to the Australian healthcare system. It's been a privilege being and wise group of people. So on that note, can I wish you and the conference the very best. I'm sure you'll learn a lot, and I hope it's very stimulating for you. Thank you very much.
Thanks very much, Shane. And you've been very efficient in your presentation, so we think we might, we've actually got time for a question or two, if you don't mind. We've got a couple of questions coming through in the live Q&A, so thanks very much for your engagement to the delegates very early on. So, Shane, a couple of questions about the value-based care and the future funding direction. Is the current thinking of bundles and case mix capitation constrained by the current jurisdictional splits for funding and responsibility of service delivery? Or is now the time to consider a bundle or case mix capitation payment that incorporates primary care?
That's a very good question, and someone clearly understands where we're heading. I'll say first of all, one of the limitations of a bundled payment is the fact that part of that bundle might be delivered by a Commonwealth program. We had a go at this a couple of years ago I think it was more to experiment how we could do it with maternity services and just with a normal. What we found was that the shared care issue was a major problem. So if a GP, then effectively our bundle would be paying for both. The provider, I guess, would be paid for both from a hospital perspective and from a Medicare perspective. So this highlights the importance of having the individual health identifier and being able to, at a minimum, to adjust the payment to reflect what's already being paid by Medicare. So I think that's, in answer to the question, that's the minimalist view that we could have, more or less an adjusted payment. And we do this now with private patient payments, so that's not unrealistic. To go the next step and say, can we truly, particularly for capitation, combine primary health and hospital? I think it's a very exciting possibility. And there are converging directions in this. I know in the land of GPs, they are increasingly interested in different payment models that are effectively capitated. And if we could combine what's spent in a hospital with what's spent on a person in primary care, assign that primary care person to a regular GP, possibility of exciting side of it. And if we have done our side, then the next step is a much easier one to take. So yeah, it would be very exciting. I just would make the normal plea for being realistic here as well, that you do it in bite-sized pieces, and that way, as I say, it doesn't let everybody off the hook by thinking high talk, and it means that we can, learn from our mistakes as we go. But that's certainly the direction I think we should be taking.
Okay, great.
Are there any other questions?
Time for one more question. quite relevant given your experience, Shane. Any views on the future funding for mental health services?
Of course, my personal involvement in mental health service funding goes back to a project called MHCASC, which feels like 300 years ago and 5 lifetimes ago. Look, I believe mental health loses in a block funding environment. It loses because it doesn't necessarily keep up to pace with growth in demand, which is what activity-based funding helps you do. It loses in the sense of efficiency incentives. At the moment, the Productivity Commission actually did some work on what proportion of time a mental health worker spends in direct patient care, and it was something like 20% of their time. So whether the data is right or wrong, it's probably a data problem. But the incentive of activity-based funding is to use your existing resources more efficiently, to treat more people with the resources that you've got. So I'm a strong believer that we need to move away from block funding in mental health, and I believe it's not just IPA paying hospitals differently, it's also states paying area mental health services differently, so they are actually funded for the work that they do, adjusted for complexity. It's a particularly challenging area because it's over time. It's actually, in a sense, a capitation model. So technically it's quite a difficult and challenging area, and I think we've all struggled with that. But in my view, absolutely mental health should not be disadvantaged. It should not be worse off than acute hospitals, and the incentives should be exactly the same. Fund fairly for what you do, incentivise meeting that incredible amount of unmet demand in the mental health world with the incentives that come with ABF. Sooner the better.
Yeah. Great.
Not another
Thanks,
5
Shane.
generations, another 5 lifetimes.
Exactly. All right. Well, thanks very much, all of the delegates who engaged with that Q&A session. Really good to see that engagement so early in the conference. And thank you so much, Shane, for your address. Really, really interesting, and focusing on the themes of the conference and where we're going with ABF into the future. So thank you very much.
Thanks, Sarah. Thanks, everybody.
All right, we're now going to have a break in the conference program. However, we've set up a networking session for those who are interested in meeting colleagues and like-minded individuals. The session running for the next hour is set up with newcomers in mind. So if you're new to activity-based funding or have never attended an activity-based funding conference before, this is a great opportunity to meet some other newbies. The sessions run in 15-minute blocks. Just head back to the timeline. Yes, I'll be parroting that for the remainder of the conference. And click on the 15-minute block you'd like to join. Please note that these sessions are unmoderated, so please keep the code of conduct in mind, and note that IPA does not endorse the views and opinions expressed in these rooms. Have fun, and I'll see you in an hour.